Buenas noches. Gracias a todos por participar con nosotros esta noche tan importante en un tema realmente, pues, del cual debemos aprender muchísimo por el potencial que tiene de ayudar a nuestros pacientes. Tenemos el honor de tener a la doctora Nalini Chilkov esta noche. La doctora Nalini es una autoridad líder y pionera en el campo de la atención del paciente oncológico de una manera integrativa. Trabaja también con prevención de cáncer y el fortalecimiento del sistema inmunológico. Tiene más de 35 años de experiencia, combinando lo mejor del mundo de la medicina funcional y la medicina occidental tradicional. Además, es acupunturista. Es la fundadora del Instituto Americano de Investigación y Educación en Oncología Integrativa y la creadora del sistema OutSmartCancer. Los programas de OutSmartCancer de la doctora Chilkov para pacientes y su formación profesional para médicos son reconocidos como los programas más completos, basados en evidencia, seguros y naturales para apoyar a pacientes con cáncer, sobrevivientes y aquellos que no quieren desarrollar cáncer para recuperarse, mantenerse bien y vivir bien. Sus servicios de consulta para pacientes y médicos están disponibles a través de servicios de telemedicina a nivel internacional, a través de la Clínica Chilkov en Santa Mónica, esto es en Los Ángeles, California. La doctora Chilkov, bueno, he tenido la oportunidad de escucharla en diversas ocasiones en los Estados Unidos. Realmente que su participación es muy valiosa. Vamos a aprender sobre el uso de la suplementación, el cuidado de nuestros pacientes oncológicos. Vamos a dejar la sesión de preguntas y respuestas para el final. Sí les voy a agradecer que vayan escribiendo sus preguntas en el chat de aquí mismo del Zoom para que estén listas ya para cuando entremos en la sesión de preguntas al final. Entonces, bueno. De nuevo, gracias a todos por acompañarnos y en este momento ya los dejo con la doctora Nalini.
Thank you.
Doctor, are you ready?
I'm ready. I even speak a little Spanish, so I got some of that. So thank you everyone for joining us tonight. I'm really honored to be here. Tonight I'm going to talk about how to use supplements in the integrative oncology setting. And I have a lecture that really has about 3 hours of content in it, but I wanted you to have all the slides. So please allow me to go quickly through the first half so that we can get to the real implementation intervention part so that tomorrow, if you have a patient, you know what to do. Okay. All right. So here's my big question. What if every cancer patient had a plan for their health and not just a plan for their disease? I want every patient to have a health plan and a disease plan, and I expect my patients to be outliers because they have a health plan. And so we can do something much more comprehensive. And in the oncology setting, health doesn't even come up as a conversation. So we want to assure patients that we have a plan for their health after they complete their cancer treatments, and that we want them to be healthy while they're going through their treatments. And so there's so much that we can do for them. And this is my mission, is that you be comfortable with working with cancer patients in this way. And it's really important. In the United States, there's a shortage of oncologists and primary care providers. And so it often falls to primary care physicians. Somebody's got their sound on. Could you mute them, please? Thank you. So it often falls to the primary care provider to support these patients. And quite often that doctor is not comfortable treating this patient population because you don't have training in this specialty. So I want to show you that your knowledge of functional medicine and nutritional medicine is the ground and sufficient for beginning to work with these patients. I want you to feel confident that you have enough knowledge to do so, and that you be the health expert on the team, so that we have collaborative teams that are health focused, taking care of patients with a whole biosystem approach, a whole system approach, but always research informed, so that we can work as respected members of an oncology team. And so I'm going to show you this health model that I've developed as my OutSmartCancer system. And all of you know that the rates of cancer and cancer survivors are going up, and that we really have to introduce a health model into oncology. Now, it's also true that cancer is not urgent care. Cancer is a chronic metabolic syndrome. And once someone is diagnosed with cancer, we really should think about caring for them for the rest of their life, to keep them well, to keep them healthy, and to reduce the anxiety of the cancer patient by reframing this and introducing the idea that cancer is not an emergency, that it is a chronic, long-term challenge, and that it's also not something that happens fast and finishes fast, but it's kind of like a marathon. And so we have to give them enough support that they feel, the patient feels confident going through that. So we, of course, we want to always take a whole biosystem approach, right? And we want to support cancer patients at every stage of the journey. So this is how I think about it. I think of 5 different stages of the journey. When a person is just diagnosed, when they're undergoing treatment, when they're recovering from treatment, then when they may be living with cancer as a chronic illness, or the patient in remission who has no evidence of disease. So that's how I think of the 5 different stages that have unique needs. And what can we do? We can really transform their outcomes, their prognoses. We can enhance and synergize with oncology treatments. One of the most powerful things we can do is manage adverse effects, both short-term and long-term. And I'm going to spend a lot of time talking about that today. But most important, we're going to provide a health model that is absent from the oncology setting. And we're going to also focus on quality of life. But even more important, my goal at the very first visit is to give the person back a sense of control and a sense of agency, meaning that in the oncology setting, it is common for the patient to feel disempowered, disenfranchised, and at the effect of the cancer team. But I want my patients to feel that they are the head of the team, and we just serve them and work for them, and that they get back their decision-making power about their own bodies, their own lives, their own care decisions. I think that's a very important thing that we do for them. Now, with your training, you can immediately start with food and lifestyle interventions. Did someone want to say something? No. Okay. So you can start here because you can be on solid ground here. And so patients have increased needs for nutrients and calories and for protein. They have a need. Somebody's got their mic on. So if you could all mute your mics, please, I'd really appreciate that. Thank you so much. So all patients need nutrient density, calorie density, high levels of protein, glycemic control, inflammation control. They need healthy microbiomes. They need to have good digestion and absorption and elimination, and they need to sleep well and to keep exercising, remembering to hydrate, and to manage stress. These are things you already do. So I want you to feel comfortable doing them with cancer patients as well. So, of course, in this model, we try to focus on etiology and not so much the signs and symptoms. We definitely want to manage symptoms so people are more comfortable, but we really want to try and give them more foundational support as they go through this. So I think it's really important to know how to take a history of a patient who either is currently undergoing cancer treatment or is about to, or a patient who's a cancer survivor who may be in your practice looking to get their health back or to avoid a recurrence. So towards that end, I have this OutSmart Cancer Care Planner as a gift for you. And so I want you to have that so you think a little bit differently about taking a history of someone who's had cancer. So for example, say someone comes in, they had breast cancer treatment maybe several years ago, but they still have ongoing cancer-related fatigue. So because of their cancer history, because maybe they had chemotherapy and that may have damaged their bone marrow, their fatigue may be due to their bone marrow ablation and not due to thyroid, for example. So you want to be able to think through where is the center of gravity of the symptom picture you are presented with this patient, and do your good functional medicine analysis to look for the factors contributing. But this guide, this cancer care planner, will help you to understand questions to ask the patient to get a really good cancer history so you can do your discovery and planning with that in mind. And this is part of an oncology course that I teach. So I'm really hoping some of you will be inspired to join us, because this is my life's work, really. And then I have a discount for you. So you'll have that in the slides. All right. So let's talk about patients who are living with the sequela of cancer and cancer treatments, and those patients who are living with cancer as a chronic illness, because that's an increasing population of patients. So there are, of course, now patients who get diagnosed earlier, get well treated, and they live maybe decades after their cancer-free, or we have this large population now of patients who may be cancer survivors, who have some burden of disease and are going to live a long time with that and maybe die of something else. So think about breast cancer patients, prostate cancer patients, some colorectal cancer patients. They live a long time, they could live a long time. And so they're looking for us. They're looking for us to help them get their health back and sustain their health and avoid a recurrence or avoid progression of a low level of disease. So we can absolutely do that. So I want to just show you that I made these slides. I was given a list of the Designs for Health supplements you have in Costa Rica. And so I made a list of all the supplements that you can use in this context. I'm not going to go through them all in a linear fashion, but I just want you to know these slides are here and that I picked out the supplements from Designs for Health that can be used in the cancer setting with cancer patients. And then I'm going to speak a little bit to groups of them. So for example,
Rayos, ¿por qué no sé?
please turn off your mics. Please mute yourself. Thank you. So in the cancer setting, we have cancer is considered to be a mitochondrial disease, a mitochondrial syndrome first. Historically, cancer is often thought of to be a dysfunction or damage to the DNA, the nuclear DNA. But more current thinking is that first, the DNA in the mitochondria are damaged because more vulnerable DNA, less protected, and just the functional parts of the mitochondria are more susceptible to oxidative stress and environmental toxins. So then with the dysfunction of the mitochondria, then signaling to the nuclear DNA then becomes involved, and then you get that part of it. So we are very concerned in this framework to protecting the DNA from these environmental insults and of toxins and oxidative stress. So these are some of the supplements here that can address that. And so when we look at giving cells more protection from oxidative stress, we can think of things like lipoic acid, CoQ10, glutathione, resveratrol, vitamin C. So these are all super antioxidants. So the only caution when you use antioxidants in this population is patients receiving radiotherapy should not concurrently have high levels of oral antioxidants. Nutritional levels are fine, but also remember that the effects of radiotherapy last for about 3 weeks after the last treatment. So you have this window, you don't want to interrupt the positive effects of the radiotherapy. So caution there. And the other is many chemotherapy agents work, their mechanism is to increase oxidative stress in the cell and thereby damage the DNA or the mitochondria of the cancer cells. So you want to be mindful not to be using a lot of antioxidants when the therapy is pro-oxidative. So you have to just think about when is it appropriate to use these things. So I have some references about this list of supplements that can be used. I'll just quickly go through this because I do want to get to the meaty part of the lecture, but the active form of vitamin B6 is pyridoxal 5-phosphate, often abbreviated as P5P. And this is particularly useful in dealing with some of the side effects from doxorubicin and from 5-FU. And so the hand-foot syndrome, we can use about 50 milligrams of B6 in the active form will often mitigate some of those symptoms, stop some of the peeling of the skin and some of the neurologic symptoms. Zinc is extremely important in cancer physiology. Number one, it competes with copper. Copper is required for angiogenesis, the ability of cancer cells to make a capillary blood supply. So zinc will compete with the copper demand for that. But zinc in and of itself is very important to cancer immunity. And it will really have an influence on natural killer cells and the generation of interleukin-2, which is a therapy in cancer treatments, has some antioxidant and anti-inflammatory capacities. And when it is combined with molybdenum, it inhibits VEGF. There's a typo on this slide. It should be VEGF. And so it can be used in anti-angiogenic therapies. Now, there are many of my patients who decline the use of some of the anti-angiogenic therapies and because they don't want any more drug therapy. So then we can go to some of the botanicals and phytochemicals and nutraceuticals that also inhibit angiogenesis, or we can go to oral copper chelation to inhibit angiogenesis. So that's a big lever that we have is inhibition of angiogenesis once the tumor burden is low, okay, once like after treatment. Also, I want to bring your attention to the importance of the microbiome and making sure that you attend to the health of the microbiome. That can be with fermented foods, soluble fibers, and then of course prebiotics and probiotics and sometimes postbiotics like butyrate. So we know there are studies that show that patients with a healthier microbiome have a better immune response both to chemotherapy as well as checkpoint inhibitor immunotherapy drugs. And so also it's a given, anybody who has been through chemotherapy or has had radiation to the pelvis or the abdomen has had their microbiome disrupted. And so you don't even have to test. You can assume that their microbiome is disrupted and have a plan to teach them how to allow that ecological restoration with diet and supplements and sometimes some herbs. Also, resveratrol supreme is really one of the great supplements for the cancer patient because both resveratrol and quercetin, the resveratrol supreme is a combination 1-to-1 of those, and interacts with multiple pathways. But in general, the plant medicine that we use, the phytochemicals and the whole botanical extracts that we use are really exerting epigenetic effects. And that's really the gift of this kind of medicine. It is also what makes it so safe because we're not actually applying a lot of toxic therapies. So we'll say that integrative oncology is not very good at decreasing tumor burden. And that is always your first intent when a patient is diagnosed. So in that sense, we may want to use the more aggressive and toxic therapies of conventional oncology to reduce tumor burden. But at the same time, we can exert these epigenetic effects and try to have a metabolic impact on the cancer cells and slow them down and turn off some of these proliferative pro-angiogenic pathways. So that's where our strength lies. And that's why plant medicine works. That's why it matters what you eat, because these phytochemicals are exerting these epigenetic effects and decreasing proliferation and metastasis. And so, and then slowing down the metabolic rate of tumor cells. And so that is something we can reliably do. Glutamine is widely used in the hospital setting today, but in the cancer setting, it is used to repair the epithelial lining from the mouth all the way down to the anus that is disrupted by many chemotherapy drugs that, of course, are having their primary effect on fast dividing cells. And so that would be the lining of the gut as well. So you see mouth sores, you see enteritis and gastritis and pretty bad diarrhea. Sometimes reflux, acid reflux. So we need to repair that lining. Glutamine does that really quickly. Also, glutamine can be used to repair neurons. And so for patients, again, fast dividing cells at the high metabolic rate, like neurons, are damaged by a lot of chemotherapy drugs. So we want to protect and repair the neurons. Glutamine is a factor in that. With oral mucositis, you can make a little mouthwash of glutamine, have the patient rinse their mouth a couple times a day and really get some quick repair of the oral lining, which then allows the patient to eat well and maintain their nutritional status and their weight. So those are some things to think about, some of the more common supplements. So let's look at supplements. Let's look at nutritional needs, and then we'll look at specific supplements. So, there's a lot of statistics linking dietary patterns and dietary habits to many, many cancers. I think it's more than 35%, quite frankly, but this one reliable study, and it's all types of cancers, from solid tumors to hematologic cancers as well. So we, of course, want to do patient teaching about diet, and I'll go through some of my ideas about what's right for cancer patients. So cancer patients have a really high need for protein. Sarcopenia, the loss of muscle mass, is a risk factor for every cancer patient. The physiology of cancer, the upregulation of inflammatory cytokines and matrix metalloproteinases really causes sarcopenia to start at the beginning of a cancer diagnosis. It's not subjectively perceptible, but it is happening. And it's also, though, that microenvironment is also breaking down the blood-brain barrier. And so early on, cancer patients may have cognitive changes or mood changes that are not chemo brain, but cancer brain. So be aware, these are early changes in the physiology of all cancer patients that we can impact. So I want my patients to have about 1 gram of protein for every pound of normal body weight. So that means patients should be aiming for somewhere between 100 and 150 grams of protein a day, which is a lot of protein. So I can't eat that much protein, and a lot of patients can't because they're not interested in food, or their appetite is gone, or their stomach hurts. So I have some strategies to capture amino acids for those patients, like a protein shake or branched chain amino acid powders, so you can accomplish enough intake of amino acids in a day to not have loss of muscle mass and to be able to repair, right? And to maintain your neurotransmitters. So I focus a lot on protein. I focus a lot on adequate calorie intake because of this loss of appetite or pain with eating or disinterest in food. We have to have strategies to help people get enough calories and nutrients. So how can we get nutrient density into their diet in a way they can eat? Many cancer patients do have inflammation in their digestive tracts as a result of their treatments they're receiving, or nausea. And so I use shakes a lot. I use therapeutic shakes as meal substitutes or calorie and nutrient repletion. So I'll show you that. Our patients need a lot of fatty acids. Most of these patients should be getting most of their calories from proteins and fatty acids and lowering their carbohydrates. So I do not put people on ketogenic diets for the most part. I have an entire lecture on that. That's on the Designs for Health website. So you can look for that if you want to hear that lecture. But the research is not strong in ketogenic diets and cancer. There's a lot of proponents of it, but the research is very strong in intermittent fasting and low glycemic diets actually having a positive impact on cancer survival and rates of recurrence. So I stick to that, but it's also easier for patients to successfully implement a low glycemic diet where ketogenic diets are difficult. So focusing on the macronutrients, mostly the calories come from fats, proteins, and lots and lots and lots of vegetables to get your fiber and your phytochemicals. We want to pay attention to the micronutrients, zinc, magnesium, selenium, the methylated form of B vitamins. Vitamin D is crucial. I'm going to talk about that more. We want to make sure that our patients are replete in their fluid and electrolytes, but we want to use electrolyte supplements that are low calorie, so low carbohydrates. Athletes use high carbohydrate electrolyte replacement, but we want to look for low carbohydrates. So ElectroPure by Designs for Health is a great one. I don't know that you can get that in Costa Rica, but look for that kind of if you feel your patient needs an electrolyte powder of some kind. So you're in a hot climate, your patients will easily become depleted of fluid and electrolytes if it's not part of the patient teaching. And some patients need IV replacement after they have infusions or surgery as well to keep them from being dehydrated and depleted in their electrolytes. And then, of course, mitochondrial nutrients are key. So this is sort of the general guidelines that I give all patients, and then we, sort of figure out, if they're a diabetic patient or they're a cardiovascular patient or they're an autoimmune patient. Our patients are going to be comorbid because of the age demographic. And so we want to be able to individualize everything, but these are the principles. And so I've actually started to increase my protein percentage in the last 2 years. And so this is just a reiteration of what I just said, but I always want to include fermented foods to have the health of the microbiome. Usually I'll put a probiotic in. The diet should, of course, be chemical-free, hormone-free, organic, whole foods when possible. And also I limit dairy especially in patients for whom it's an inflammatory trigger or for patients with estrogen-driven cancers, and talk to patients about where estrogen occurs in animal foods so they can be thoughtful about what they're eating if they have an estrogen-driven cancer. However, we do not restrict soy. There's been a lot of research on soy and phytoestrogens actually decreasing the rates of cancer, estrogen-driven cancers. There's a big study that was done in China where soy is a huge part of the diet, and it showed that patients who eat soy earlier in life, women who eat soy earlier in life, have lower rates of estrogen receptor positive cancers relative to the general population. So soy is not restricted. And then we just teach people about, not eating blackened, over-grilled food proteins. We make sure there's plenty of fiber in the diet. And of course, if it's a plant-strong diet, I don't put people on vegan diets, but the reason is it's hard to get enough protein and it's hard to eat low glycemic on a vegan diet. So if someone is wanting to do that, then they need to work with my nutritionist so that they really aren't getting too much carbs and not enough protein. So it's a little harder work to do that, but it's possible. Usually it makes it easier to put a protein drink. We want the diet to be anti-inflammatory, to have lots of color. I always say eat the rainbow so you get a lot of antioxidants. Include a lot of herbs and spices. Of course, this is part of your traditional diet. And so, of course, we're getting lots and lots of phytochemicals and aid to digestion that way. And I restrict red meat and alcohol, which are both known carcinogens. for cancer, many cancers. And then I also teach people not to store their food in plastic because plastic particles get into all of our food, and now it's in breast milk. And so those are the big ideas for my OutSmart Cancer diet. And then I mentioned I give all my patients a therapeutic shake. So I want that shake to have about 30 grams of protein in it so that we can try and get to 120 grams of protein at least every day. And so some patients, they don't feel like eating after their infusions. Maybe they have 2 shakes a day to try and accomplish that. Then I like to put a greens powder, reds powder in there. I like to put carnitine into the shake for its ability to promote mitochondrial function, but also its ability to oppose sarcopenia and help to maintain muscle mass. Then I put soluble and insoluble fibers. So, you can put chia seeds and spinach, or, you can do that with a fiber powder. You can do it with plants. I also, in some of my patients, I'll put medium chain triglycerides, or you could just put coconut oil in the shake to get some of those to add more calories for patients who are having trouble eating enough calories and who are losing weight. And then I'll usually put a Chinese medicinal mushroom blend into the shake for immunity, immune enhancement, some tumor control, some glycemic control, some inflammation control. But the only contraindication would be a patient who is receiving immunotherapy. I withhold those Chinese mushrooms because the immunotherapy today is used rather unskillfully, in my opinion. And so we don't want to add to the excess inflammation. So I withhold things that are really immune stimulants, like Chinese mushrooms, like Ganoderma, Coriolis, cordyceps. And I might also withhold something, astragalus, that's quite often used in cancer care to boost immunity and to boost white cells. But it actually aggravates the pro-inflammatory adverse effects of the immunotherapies. So caution on that. Then I'll have them put a non-dairy liquid and some organic berries and try to have them make it taste good. But I am restricting fruit. So I don't want them to have high glycemic fruits like bananas and pineapples. But actually, mangoes are okay. They don't really cause a glycemic spike as much as some of the other tropical fruits. Now, vegetarian diets are known to be less associated with cancer risk. And that's really because a person eating plants is not exposed to the environmental toxins and hormones that are in food sourced higher up on the food chain. And so it's largely that. It tends to be a lower iron diet. We restrict copper and iron in cancer patients because both copper and iron are utilized by cancer cells for their own proliferation and progression and metastatic progress. So an animal-based diet will be higher in copper and iron as well. So I restrict alcohol in my patients because it's a known carcinogen. There's no healthy reason to use alcohol. So, that's a negotiation with a lot of patients. But head and neck cancer, esophageal, liver, breast, and colorectal are particularly associated with alcohol consumption. Now, let's talk about vitamin D. It's huge. So I recommend that you measure vitamin D levels in all of your patients. I always measure 25-OH vitamin D because it is so powerful. And there are so many studies showing that low vitamin D levels are associated with poor outcomes, poor prognosis, and poor survival. And that a lot has to do with its impact on cancer immunity and its impact on cell adhesion. So cells that can't stick together as well are less likely to form masses that are hard to treat. So it really modulates the development of cancer, the progression of cancer, and it affects prognosis and outcomes and prevents recurrences. And so it also has a positive impact on cancer-related fatigue. And for those of you who are aware that vitamin D is often used in the management of depression as well. And so cancer patients are anxious and depressed. And so we want to make sure that we're addressing all of their needs. Here's just a review. I'm not going to read it to you. You can come back to this slide, but vitamin D has over 50 functions in the tumor microenvironment and the cancer physiology. And so I think it's very important to measure it. And multiple types of cancer have been studied relative to vitamin D levels. I have quite a few references here for you. And it has also been studied in cancer-related fatigue, and as well as cachexia, which is an end-stage metabolic inflammatory process where there is a rapid loss of muscle mass. And this leads to frailty and often death. And so you want to try to intervene with that and stay as far away from that. I will say that if you have patients that are starting to tip into cachexia, they're having rapid loss of muscle mass and high levels of inflammation, this is what I do. I give them 10 grams of omega-3 fatty acids spread out over the day, and I give them very high levels of protein. And that will often stop that process. So that means they just take a lot of shakes, or they take protein powder, put it in a glass of water and drink it every couple hours if that's all they can do, because they're often quite weak. But this physiology prevents them from transforming nutrients into an anabolic, positive anabolic outcome. So that's a real challenge, but I have seen you can turn it around. You can absolutely turn it around. So more references on vitamin D. So my goal is to have 25 OH vitamin D between 70 and 100. And so I often will also look at 125 OH vitamin D, because with the increasing use of immunotherapies, autoimmune patients and patients who receive immunotherapies who become autoimmune patients because of it will utilize vitamin D at a higher rate. So I kind of want to see what's going on. So I've started ordering both 25 OH, the storage form, and 125 OH, which is the active form. And so remember that we have now this switch in how we're reporting our dosing. So I have a little chart in here for you for that. More references on vitamin D. There's a lot of them. Now let's talk about how to treat the side effects of cancer and cancer treatments. So this is the part I really want to focus on. So there are lots and lots of adverse effects of the disease itself and of cancer treatments. So I want to touch on some of them, okay? And if you want to do another one of these webinars, we'll take a deeper dive, we'll talk about more. So cancer-related fatigue, cancer treatment-related fatigue is the most common adverse effect. And it is experienced by 80 to 100% of patients. And sometimes patients do not report it, but you should inquire. You should inquire. So we want to support the mitochondria. There are common causes for cancer-related fatigue. One of them is mitochondropathy, okay? Another one is inflammation. Another one is having not enough protein. And so we want to be able to address different etiologies, and the other is bone marrow ablation. And so we want to have strategies for addressing the root causes of cancer-related fatigue. So you think about, for mitochondrial support, think about methylated B vitamins and the twice daily multi, and magnesium also is very important for the mitochondria, and carnitine. I like to use adrenotone for, this is a formula filled with adaptogens. And then cancer patients often have disrupted sleep cycles, either because they've been in the hospital and had their sleep cycle interrupted several times a night, or they're in pain, or they are going through hormonal changes that are waking them up, or have thrown off their 24-hour clock. So, or they're just anxious, they're anxious. And so you have in your materia medica, you have pharmagaba, neuromag, and catechol. And so those are all great for dialing down anxiety and helping people to relax. Think of them kind of, the pharmagaba is kind of like a benzodiazepine, a mild benzodiazepine. And catechol really kind of turns off some of the stimulating neurotransmitters. And then the neuromag is a form of magnesium that is just easier to cross the blood-brain barrier. So you get more relaxation, more neural effect from that form of magnesium. And then, of course, we want to make sure that the fatigue isn't due to undernutrition. So you have available to you the amino acids, the collagen, the branched chain amino acids, and the amino acid synergy as supplements. I like better they get it from their food or a protein powder, but you have these supplements. This is the adrenatone with all these beautiful adaptogenic herbs in it, which I just really, really, really love. And so there's actually been some good studies. Oops, wrong way. There's been some good studies on ginseng and cancer-related fatigue, both on Chinese ginseng, as the Asian ginseng, as well as the American ginseng, which is this Panax quinquefolius. And so you have that in the adrenatone, and you can certainly give ginseng concurrently with most cancer therapies, and just don't give it too late in the day. And this is actually very, very effective if you can get good quality ginseng. Now, withania, that's ashwagandha. You may be familiar with that. It's an herb widely used in Ayurvedic medicine, but also widely used in Chinese medicine. And there have been many studies on cancer-related fatigue. There are studies that show it also supports the bone marrow, changes prognosis in terms of overall survival, improves white cell counts, enhances sensitivity to radiotherapy, improves sleep, and it's been called the adaptogen that you give to people when they're tired and wired. They're really exhausted, but they can't relax, so they can't actually get any rest or turn off their cortisol and turn off stimulation. So I usually give about 3 grams a day of ashwagandha, 3 grams a day of ginseng. In that ballpark, it's quite safe to do that. There's not a lot of interactions. Now, hypomagnesia is a common syndrome in all cancer patients, especially surgical patients and chemotherapy patients, and of course, anybody who's had kidney dysfunction. So I use the magnesium glycinate to replete tissue stores of magnesium, and just the most efficient physiologically, whereas I'll use magnesium citrate or magnesium oxide for producing a loose stool in the face of constipation due to its osmotic function in the gut. So if you want to get the magnesium into the tissue, you want to use the glycinate form. And somewhere between 500 and 800 milligrams a day is really what you need, up to 1,000 in some patients. So serum magnesium tests are completely inaccurate. And we know that, like, for example, all the platinum chemotherapy drugs cause increased rates of magnesium excretion through the nephron. And all those patients are magnesium depleted after they have their infusions. And that is why they're so tired. And so you might want to study this slide a little more to see all the symptoms. You can measure red blood cell levels of magnesium, but there's not really any great testing. But we know that these patients are excreting more magnesium, and that repleting their magnesium, especially around chemotherapy, dramatically changes their quality of life and their function. Now, constipation is a result of a number of things in cancer patients. It can be, oops, sorry, going in the wrong direction there. Okay, there we go. So it can be because they've had a disruption to normal peristalsis, either due to obstruction, due to a tumor mass, due to adhesions, or just due to drugs like opioids. It could be that they haven't been eating enough fiber because they're just not eating much. So that's a common etiology. Of course, if they've had surgery and that disrupted their normal peristalsis, the best thing to kickstart peristalsis is acupuncture. Absolutely best thing. Of course, stress and tension and pain will cause constipation, and some patients just become too sedentary as well. And so I have patients who think that when they have cancer under cancer treatment, they should sit in a chair or lay in a bed all day. But I want my patients to be as fit as they possibly can. I want them to get out and take a walk. I want them to do exercise. I want them to stay active. I want them to stay engaged in life as well. So often patients are not aware that it doesn't hurt them to go exercise as long as they're just mindful of reality. You know, there are days when it's you're tired, you should rest, but really staying fit is the most important. So it's the calcium citrate, magnesium citrate that is used with 8 ounces of water in one big dose to create an osmotic inflow of water into the colon and make the stool soft. It's extremely safe, unlike some herbal laxatives, which are irritants to the colon and which are habit forming. Magnesium is so safe. And so if you take too much, you get a loose stool. Next time you take less. If you didn't get a good effect, then you take a little more till your stool is softer. Ovarian cancer patients get a lot of adhesions around their colon, and they can have bowel obstructions as a result of that. Also, colorectal cancer patients get a lot of adhesions, and so they don't have normal peristalsis. And so keeping the stool a little softer is sometimes just the solution. You can do that with magnesium. So I've talked a lot about my concerns about cancer-related sarcopenia, and I really stress this because the oncologist is not paying attention to this at all. And I think it's crucial to maintaining the strength of the patient, but we also know that muscle mass contributes to normal glycemic control. It contributes to the myokines, contribute to normal metabolism, normal neurotransmitters, normal inflammation control. So the muscles are really an organ of metabolism. They're not just a mechanical function. And so it's really important to maintain muscle mass because cancer patients can quickly become weak, and then they stop exercising and get depressed. It's a downhill slide. So I've spoken about my interest in increasing protein intake. This I just make this a focus, and I talk about this with patients. So the main interventions are fatty acids and carnitine and oral proteins or amino acids. So you go up to about 3 grams of carnitine a day. And this really can also kind of stop the rapid loss of muscle mass. Give about up 2 to 6, sometimes 10 grams of fish oils, but you can't anticoagulate your patient. So somebody has really low platelets, you have to be more conservative. So I would start slow, and you can also, you'll notice if you're doing labs, if you're at least ordering CRP, C-reactive protein, I also track IL-6 on my patients, interleukin-6, you'll see that goes down as this resolves as well. You'll find that patients with high tumor burdens have very high CRPs, very high IL-6, sometimes a high SED rate, sometimes a high uric acid, all these markers. Quite often, cancer patients with a high tumor burden will have high ceruloplasmin and high ferritin as inflammatory markers. So if you start doing these lab tests, tracking the tumor microenvironment, you'll start to see the picture of what it looks like, and then you'll see how your interventions help them, and you'll also see how when tumor burden goes down, a lot of these things go down with it. So you can become familiar with assessing the urgency of your interventions with your patients, and sort of their status and how vulnerable or fragile they are, what their prognosis might be. Now, neurotoxicity is primarily due to increased oxidative stress in the neuron due to pro-oxidative and pro-inflammatory therapies. So you can use glutathione, both IV and orally. If you use it orally, it needs to be liposomal glutathione. And just sidebar, I use liposomal supplements in patients who have trouble swallowing pills. It's very expensive to do that, but it allows them to get more of the nutraceuticals that I want them to take. So I do that in some patients, especially patients who have gastrointestinal cancers or just people who just have a gag reflex when they swallow pills. So you can use glutathione. You can also, of course, use N-acetylcysteine, and whey powder is a source of N-acetylcysteine and glutathione production as well. But you go high. You go to a high dose to try to quench more of the oxidative stress. Glutamine is also a repair nutrient. And so you can use that also in high doses, and that's the dose that also will repair the lining of the gut if the epithelia have been are turning over due to the chemotherapy they may be receiving. Now, with the advent of more immunotherapy and less chemotherapy, that's a really good thing. And we get a whole nother set of adverse effects that we have to manage. So for those of you not familiar with the new immunotherapies, think of the immune system as a brake and a gas pedal. It has an on switch and an off switch. And so in many cancer patients, the tumor cells have disabled the immunity, have disabled the T cells, and the normal immune response has been disrupted. So the intent of things like the checkpoint inhibitor and PD-L1 inhibitor drugs is to take the brakes off of the immune system and let it go after the cancer cells. Now, this produces autoimmune disease in these patients. And so we have to be mindful of that. It is my experience that oncologists have no training in immunotherapy side effects management. They all just throw corticosteroids at it, but that is not a healthy approach. So I could give you a whole lecture on this, but I'll just say that you have to be on the lookout for thyroiditis, arthritis, colitis, sometimes pericarditis. So we will find, and certainly dermatitis, the skin rashes. So these are the common autoimmune effects of overstimulating the immune system with these drugs. So in a more skillful evolution of this, I am hoping that what we'll see is, instead of creating a forest fire in patients, which is not necessary for the job we're trying to do, that we create a little nice little small candle flame or a little coal, ember, that is just keeping the immune system activated against the tumor cells. So what we're treating is the overdrive, okay? We're treating the overdrive. So what you think about, and I didn't mention pneumonitis, that's very common also. So what we're doing here is the same thing we do in our autoimmune patients in this kind of medicine. We give high doses of vitamin D. We give high doses of omega-3 fatty acids. We give high doses of curcumin, and then we correct the health of the gut and try to establish a more normal microbiome. And so again, you have to be very careful not to anticoagulate your patients, because omega-3 fatty acids and curcumin, which is derived from turmeric, inhibits platelet aggregation. And so you have to be careful. But many of these patients actually are in a state of hypercoagulation due to all this inflammation and due to their tumor burden. So sometimes it's helping to keep them from getting a blood clot also. So you have to be very thoughtful and do the blood tests, assess their coagulation status, assess their vitamin D status. I also assess omega-3 and 6 fatty acids in the blood. And towards that end, you can choose a safe dose. If you're not comfortable and not experienced, just start with the low dose, just start at the low end, which is very safe. But we can actually modulate the overstimulation of the immune system. And I have a number of resources for you here. So I want to summarize here, and then we can go to Q&A. So one of the big differences in integrative oncology compared to conventional oncology is we're not just fascinated with the tumor or the characteristics of the cancer that the patient may have. We're also interested in the biosystem that is hosting that cancer. And we call that the cancer terrain or the tumor microenvironment, which is a signaling environment. So we want to understand that. We want to address it. We want to have some metabolic interventions so that we can also work synergistically with some of the cytotoxic therapies that are used in oncology today that are sometimes necessary. So we want to exert these dietary principles that I have gone over with you, a plant-strong diet full of fiber and phytochemicals. That would be an anti-inflammatory diet, making sure we have enough nutrient density, making sure that diet is low glycemic. Why do we focus on that? Because a number of types of tumor cells are exquisitely more sensitive to the signal from insulin and to GLUT4 and glucose. They have more receptors on their cell surface. And so if we starve the cancer cell of insulin and take away the insulin signal, we get a metabolic downregulation in the tumor cells. And so just you get less progression and more control. And that buys you some time also. So that's why. So for the cancers that are more sensitive to glycemic control tend to be breast cancer, pancreatic cancer, and brain cancer. Those are the most sensitive. Remember that I like to use a therapeutic shake. Almost all my treatment plans have a therapeutic shake, and you can add lots of other things to it. And especially, I give you a basic recipe, but patients who don't like taking capsules, they can open up the capsules and put the powder into the shake if it's not bitter and do it that way. Remember that I restrict alcohol and red meat, really focus on everyone on optimizing vitamin D and zinc and protein and magnesium. Like if you do all this, you don't need any more training. You can start there if you're nervous about working with cancer patients. And then you want to be feeling more skillful about addressing the common side effects, right? So I've tried to bring those to your attention. And so fatigue, magnesium depletion, loss of muscle mass, neuropathy, hyperinflammation, constipation. These are things most people will need help with, that we have safe interventions with diet, lifestyle, and nutraceuticals and phytochemicals. And acupuncture is really great for all of these things too. I'm also an acupuncturist. So these are some of the supplements we talked about. Just want to remind you to download this care planner, which it'll help you kind of think through. If you typically are you new to working with cancer patients, think through how you want to take a history. And remember, if you're interested in the course, I would love to have you, and I have discounts and bonuses for that. And you can always contact us at support@outsmartcancer.com if you have questions or you want to need help. That's my disclaimer. And that's the end of the show. So we can go to, let me see if I can get out of my PowerPoint now. We can go to Q&A.
Thank you so much, Dr. Nalini. Excellent presentation. Very, very nice and very practical for all of us.
And I made it in an hour. How about that?
Yes, excellent. Excellent. Very practical. I love it from the, from the practical point of view of where we can get started.
Yeah, I want you to feel confident.
Yes, even if we didn't have any experience treating cancer patients, it seems like, this is an excellent, excellent guide. Okay, so we have some questions. Specifically talking about soft tissue sarcomas. Is there a supplement caution for that kind of cancer?
No, there isn't. Soft tissue sarcomas are some of the most insensitive to conventional cancer therapies. So These patients typically have surgery as the primary intervention. These cancers are not sensitive to chemo, not very sensitive to radiotherapy, and only somewhat sensitive to immunotherapy. I have found that Chinese herbs are really excellent. And, these patients tend to have significant tumor burden. So then they're going to have more inflammation. They're going to have more risk of hypercoagulation, and they're going to often have encroachment upon organs. So some of these patients get amputations. So pain management, anxiety management. A lot of these patients, kids get sarcomas. So managing anxiety is really important also. There's that particular cancer, because chemotherapy is rarely used. That's where you worry about interactions the most, is patients who are undergoing chemotherapy. If a patient's not undergoing chemotherapy, then the way you ask the question is, are there interactions? Because we don't have all the studies. If you understand the mechanism of action of the drug or the treatment they're getting, and you understand the mechanism of action of the phytochemical or the nutraceutical you're using, you can figure out if it's going to conflict just by thinking it through that way. There are some databases. There's a database called KNOW, which is part of the Naturopathic Oncology Association. Has a fabulous website, and they do fabulous conferences and fabulous webinars. And they have an affiliation with this KNOW platform. And there's a lot of good studies there. And you can search interactions on that. There's all these other interactions databases on nutraceuticals. I don't find them very useful, but that's a particularly good one. So it's ONCANP, Oncology Association of Naturopathic Physicians, oncanp.org. And from there, you can get to the KNOW database. That's a good place to look. And it's got a good search function. And one of my colleagues actually is kind of leading that project. It's quite well done. And it's focused on the oncology, specialty.
Okay, perfect. So that's a resource that we should have handy.
Yeah.
oncanp.org.
Yes, and that is, if you are interested in studying with some of the best naturopathic oncologists, fabulous instruction, fabulous conferences and webinars, really good, reliable information.
Okay,
Very experienced clinicians.
Okay, thank you for sharing that information.
Yeah.
Okay, now talking about mTOR pathways and cell growth.
Yes.
What is known about supplements such as amino acids and glutamine?
So inhibiting mTOR is a strategy, right? Is a strategy to inhibit cancer growth and progression. So it conflicts with some of my statements about eating a lot of protein and trying to build muscle mass. So you have to balance and weigh these things. There are quite a number of phytochemicals that interrupt the PI3K mTOR pathway, AKT mTOR pathway. But my favorite one that I use is Honokiol, Honokiol, because it has really a lot more studies. And I like to try at least be research informed. If we don't have double-blind, placebo-controlled studies, and at least be research informed. And Honokiol also has a lot of studies in specific cancers, not just that pathway. So it's widely used in breast cancer control, for example. Curcumin interrupts that pathway a little bit. So here's the thing. When you learn that a phytochemical like Honokiol or curcumin will interrupt that pathway, what you have to think about is what would be a therapeutic dose, because a nutritional dose is not sufficient for a pharmacologic effect. And so you have to be giving pharmacologic doses of these phytochemicals. And so I think that requires a little bit of mentoring so that you're safe. So for example, Honokiol is quite safe, but it causes a lot of digestive upset. So I'll generally spread it out and I'll give it with something like ginger tea and make sure you take it with food so you don't get so much digestive upset from it. But it's also quite sedating. And so patients are taking a high dose to try and get this pharmacologic effect, and then they feel sleepy during the day, and then that's a quality of life issue. So then I give it at dinner and at bedtime instead. So, there's the art of medicine, right? And so using herbal medicine is not the same as studying pharmacy. It's more nuanced than prescribing a drug. So, but I feel my favorite first love is botanic medicine and the use of phytochemicals and botanicals. And it is such a sophisticated art. Like in modern China today, modern Chinese herbology is extraordinary in cancer and in tumor control. I have a whole pharmacy of Chinese herbs. I make Chinese herbal formulas for my patients. And I find this to be one of the biggest levers that I have to transform the tumor microenvironment and the behavior of tumor cells. So it's not simple. It's not simple. And but I am happy to mentor people who want to really use botanicals and phytochemicals. So I think it's one of the most powerful things that I have in my treatment plans.
Okay, thank you. Now, going back to where you talked about antioxidants and chemotherapy,
Yes.
right? There are some types of chemotherapies that are pro-oxidant. And
Yes.
then in those cases, you want to use low doses of antioxidants, or you want to not use antioxidants.
So what you want to do during the therapeutic window of using a pro-oxidative therapy, that might be like a platinum drug, for example. It might be a patient receiving radiotherapy. So during the therapeutic window, you don't want to concurrently use antioxidants. You want to allow that pro-oxidant therapeutic effect to do its thing. And so you don't want to interrupt that. So with most chemotherapy infusions, except for a few of the newer drugs, the window of the therapeutic effect is like 4 or 5 days. It's 4 or 5 days. So and let's say a cancer patient is on a 21-day cycle of chemo or a 14-day cycle of chemo. So then I will wait till day 6. I'll wait till day
Correct.
6. I withhold 2 classes of drugs. I withhold anything that is antioxidant if a pro-oxidative therapy is being used. And I also will withhold things that we think of as, liver detox and things that promote the liver detoxification pathways, because that alters drug metabolism, right?
Yes.
We don't want to excrete the drug too fast. So I will withhold those classes of my therapeutics so that I am not interrupting what the oncologist is trying to do, right? But then we can help the patient recover from that, right? And so I will withhold those 2 classes of my therapeutics, allow the chemotherapy to work, and then when its window of efficacy has passed and the patient's just recovering from the side effects until their next infusion, then we can do lots of things during that period.
And you did mention the therapeutic window for radiotherapy being around
Long.
3
It's long.
weeks.
Yeah, it's long. It persists. Yeah, it persists. And
Okay.
if you're not sure, just ask the radiologist, Ask them.
Yeah. Okay, so withholding from high doses of antioxidants during the therapeutic window.
Let's talk about radiotherapy and antioxidants because there's confusion there.
Yes.
So what we know is that antioxidants in the nutrition world, so a nutritional dose of anything like from food is not going to interrupt radiotherapy. Don't worry about that. But you wouldn't want to take really high doses of vitamin A, really high doses of vitamin C, like high doses of vitamin E or tocotrienols. those antioxidants we know can interrupt radiotherapy. But we also know that phytochemicals that have antioxidant properties rarely interfere. And so you don't have to withhold something like curcumin, for example, or resveratrol. So that's a kind of a clarification that I think is important.
Yeah, that's very important.
Mhm.
All right. So we're good with the phytochemicals, right?
Yeah, not to worry.
Okay.
So radiologists often tell their patients you can't have any antioxidants.
Yes, that's
So,
why that's what we hear.
or it's similarly, a lot of surgeons will tell their patients to stop all their supplements 2 weeks before their surgery.
Yes.
Which is completely stupid because you want the patient to be well nourished before they have a surgery. So you just need to withhold these same classes of drugs that you would withhold during infusion cycles. Anything that inhibits platelet aggregation or is fibrinolytic, and anything that alters drug metabolism. But all the nutritional things, all the minerals, all the B vitamins, all the protein, you want to take all of that, you know?
Mm-hmm.
So I withhold those classes of supplements for 72 hours before the surgery. Because
72 hours.
they are food-like. You know, think you eat a carrot, right? Your carrot, the effect of the carrot is not happening 72 hours later, right? It's not happening. These are food-like. They're not drugs. And so their half-life is very short, just like food.
Mm-hmm.
Very
Okay.
safe. It's really hard to hurt somebody with this kind of medicine. So if you make a mistake and you overdose it, it will be over in a few hours. It will be over.
Okay. Got it. All right. When it comes to protein, like you're talking about the therapeutic shakes, for example,
Yeah.
would you rather go with animal proteins or vegetable origin proteins?
Well, my preference is to use whey protein because it is very high in the amino acid leucine, Leucine.
Mm-hmm.
Leucine is what signals the muscle. And so if my intent is to prevent sarcopenia, I want a high leucine source. And collagen is very low in leucine. So while it is good for connective tissue, it is not good for muscle. And so if a patient can tolerate whey, and the whey protein isolates tend not to trigger any kind of a patient who has any kind of dairy issues. So my preference is to use a high quality whey protein. The high quality whey powders like Designs for Health also are not heat treated, and therefore they still have their immunoglobulins too.
Oh, okay. And
So that's what you want to look for, right?
how about the beef, hydrolyzed beef protein?
That's collagen protein. That's what that is. It's collagen
Okay.
peptides. Yeah.
So it's still low in leucine.
It's low in leucine. Yeah.
So
And
we could add the branched chain amino
you
acid.
can do that.
Yeah.
Or if somebody wants to use a pea protein, or a vegan protein, then you have to add the branched chain amino acids then.
Okay. All right. Next question is about tocotrienols and the effect in senescent cells along with the effect of vitamin D.
Okay. So number one, there's been a lot of research on tocotrienols in cancer, particularly breast cancer, pancreatic cancer, and ovarian cancer. So, and the dose is about 1,000 milligrams a day. So you can get tocotrienols from Designs for Health in 300 milligram capsules. So, but that's a strong antioxidant. It falls into that category, but they're very interesting molecules. So now this whole area of cellular senescence, I think, is really worth talking about because cancer treatments, in the way that so some cancer treatments kill cancer cells, but a lot of cancer treatments just disable them and don't kill them. And a lot of those cells then become senescent cells and stay in your body as senescent cells. This is also what happens in aging physiology, as we start to
Yes.
have cells that become senescent. A senescent cell is a cell that's no longer dividing, but hasn't gone through apoptosis or autophagy. So these cells will be higher in patients who have received a lot of these aggressive cancer therapies. You'll have a lot of senescent cells. Senescent cells themselves secrete a lot of inflammatory cytokines.
Mm-hmm.
So they produce an environment that is pro-carcinogenic, actually. And so this is problematic. So, now that this research has come out on senescent cells in the last few years, what I have started to do is, after cancer patients have gone through large, portions of their treatment, is to say, what could we do to scavenge some of those senescent cells out of their system, in the same way we want to do in an anti-aging protocol, right?
Right.
And but there's this subpopulation of cancer patients who have more senescent cells as a sequela of the therapies they received. And so it is thought that the fact that cells have a program to go into senescence is possibly to prevent cancer from developing. So that's thought to be its healthy function, but it gets amplified in people who have had toxic therapies. Okay? So I feel that we should do something to try and scavenge cells out of older people like myself, and also out of cancer patients. So the best research is on quercetin and fisetin on that.
Mm-hmm.
And so Designs for Health has a supplement called Senolytic Synergy, which is a pretty good supplement, but really the most solid research right now in humans, like, all of us can make mice really healthy, but what about humans, right? So the best human research is in fisetin and quercetin. So, and it doesn't take a lot of either one of those nutrients. Designs for Health has a number of quercetin supplements, and the resveratrol supreme has quercetin in it, but quercetin is not very absorbable. And so it's better to get a lipid soluble quercetin, which would be from another company.
Okay.
But that's a better choice, of course. But of course, quercetin is, if you're eating a plant strong diet, you're eating a lot of quercetin already.
Yes.
So, and then fisetin is very high in strawberries, for example. So, that's my thinking. This is all very new, and that's fairly theoretical. It's just my
Mm-hmm.
thinking about it,
Mm-hmm.
And so that's not related to tocotrienols. But that was the
All
question.
right. Okay. Thank you. Now we want to know about vitamin D. And
Mhm.
what do you think is, what is your preference when it comes to vitamin D supplementation? Is it the single dose, high dose,
No,
monthly
no,
doses
no.
versus daily?
So here's what I think, you'll see oncologists giving 50,000 once a week,
Yes.
right? That's very common.
Yeah.
I don't like that, because I think you'd have to think, why are they doing that? Number one, they're doing it because I have no training in nutrition. But number two, I think it's healthier to give a daily dose. And my patients are highly compliant. If you have a patient that has low compliance, maybe that's a good idea to give it once a week. So you have to see who you're talking to, right? But my patients are highly compliant. So high doses of vitamin D can alter calcium metabolism. And so I don't want to do that. And the nephron is already very stressed by a lot of the cancer therapies.
Mhm.
So I don't want to add stress to the nephron. So I think it's better to do daily dosing. But also, then you have more stable blood levels, right? You have more stable levels.
Sure.
And so
Yes.
what we're trying to stabilize physiology so people feel well and have, good function all the time. And so it's sort of like a lot of our therapies are food-like. I think of herbs as food, right? If you think of that, you wouldn't feed someone a meal once a week. So, we eat every day. And so
Mhm.
think about what causes healthy physiology, right? So, but I'm a pragmatist. So if I have a patient in front of me who's really low compliance and I know they're not going to take their vitamins every day, I might do that just for that reason,
Yes.
you know?
Yes, absolutely. We agree. All right. Next question. What about the use of CBD for sleep deprivation and the anxiety and depression related to the effects of cancer treatments?
So CBD is highly available in California, where I practice, and in good quality. So I think for some patients, it's a great solution. CBD is an absolutely great solution. It's great for the autoimmune stuff also.
Mhm.
So I have no objection. There really aren't a lot of interactions. I think it's quite safe. So I don't tend to prescribe it because I'm really interested in all the other herbs I use. But if a patient wants to use it, I have no objection. I don't think there's many contraindications to using it.
Okay, and
But let me
no,
just say something about
Mhm.
THC, okay? Because
Yes.
because THC is a whole nother thing. THC is what really exerts a therapeutic effect on tumor cell metabolism. However, you have to take THC in really high doses to get an effect on tumor cells. And most patients will be stoned out of their minds on that dose, and they can't
Yes.
function in their lives. And so I explain that to people. I say, you can use it, but you will not be able to drive. You won't be able to remember to pick your children up from school. So, it's too disruptive. I want my patients to have normal lives. I want them to be able to engage in life as normally as possible. So I tend to stay away from things like that
Yeah.
because I have a bigger toolbox. I could choose other things.
And on the other hand, in Costa Rica, the only CBD that we have available is THC free. That's all we have.
So then you don't have to worry about that. And if you have a good quality CBD and the patient tolerates it, you can think about using it for sleep, for anxiety, and for autoimmune inflammation.
All right. So it's okay to go with the CBD THC free. That is what we have.
That's my preference, actually. Right?
That's your preference.
Yeah.
Okay, excellent. Okay, we have another question. If you were to advise patients, with high risk of developing cancer, what supplements would you use as a base?
Okay. It's a great question. So the way we want to think about it is, and this is kind of like one of my taglines, is how do you create a body where cancer cannot thrive? How do
Mhm.
you create a tumor microenvironment, a biosystem that is not likely to host cancer, either allow cancer to develop or proliferate or spread? How are you going to create a body like that? And I'll just tell a personal story of how I got into this. Is both of my parents were diagnosed with different cancers in their 50s. And so that's how I got into this. And then I started thinking about something environmental we were all exposed to, or is it our genetics or genomics? Like, what is it? So I don't know the answers to any of those questions, but I wanted to create a system that would be resistant to hosting cancer. And so that's sort of how I think about it. Okay. And so what we're really trying to do is exert epigenetic effects by our lifestyle, our behaviors, our stress management, our diet, and then supplementation, right? So I will generally and the age demographic for most cancer patients is over 50, although we are having an alarming increase in patients in their 30s and above now. But historically, the demographic was patients over 50. So that age demographic can also have iron-free supplements. And because we don't have menstruation going on in women. So, and we know iron is just pro-oxidative if you don't need it. So, so I use a multivitamin that is cancer-free, is iron-free and copper-free, because both copper and iron drive processes in cancer cells that are proliferative. and you will get enough iron and copper from a healthy diet. So we just don't add it in a supplement. And we want the methylated form of B vitamins, and we would prefer our multi to have tocotrienols and not tocopherols. So that's the perfect supplement, right? For a multi, because you want to have a plan for your micronutrients, right? You want to have a plan for that.
Yeah.
Then this age demographic needs support for bone health. So I'll have some kind of a bone supplement. I really like the OsteoBen that Designs for Health makes, but I think you only have OsteoForce available.
Yes, we do.
And that is that's copper containing. So
Mhm.
that's my objection to that.
Mhm.
And then some vitamin C with bioflavonoids, for healthy epithelia and good immunity, and all the bioflavonoids exert epigenetic effects on many pro-cancer genes. And then I will put in vitamin D. I'll put in omega-3 fatty acids and a probiotic. And then I'll put in some Chinese herbs. That's what I consider the foundational part. And then you want your macronutrients to be addressed. So that could be through diet or diet and a shake, right? So that's sort of, the basics. But then if there was a particular cancer that runs in your family, then you might want to think about some other things. So let's say estrogen receptor positive cancers run in your family, then you might want to put something with sulforaphanes like the Braco Protect in there, right?
Yes.
You might want to do that. Or you might just want to make sure you eat a lot of broccoli and kale or something like that. If you say pancreatic cancer or brain cancer is your concern, then you'd want to be very strict on a low glycemic diet, very strict, and try not to trigger insulin as much as possible. So, you want to think about it that way. You also, some people, there was a very interesting study at UCLA on looking at the genomics of patients who have inflammatory histories, right? And it was found that patients who tend to produce more interleukin 1B, interleukin 6, and TNF alpha tend to not only develop more inflammatory diseases, but more cancer. And so then a given patient might want to have more emphasis on inflammation control. And you can just take a history of somebody, and if their whole life they've had inflammatory syndromes, you could say inflammation needs more weight in your treatment plan. So you think about the next part of the treatment plan is what I call, the targeted part. So we have the foundation supplements, which I just named, and then we want to have some targeted things in there. But you also think about things that are good for a lot of cancers: curcumin, EGCG, resveratrol, quercetin. So you could just put those in, and you would then be dealing with your senescent cells as well.
Wonderful for all
Right?
of us. I mean, that's something that we could all do.
That's
Even
right. That's right.
yeah, absolutely. So one of our attendees tonight, she says she's a breast cancer survivor, and she's now with hormonal therapy and with some effects as articular pain, joint pains.
Yeah.
What supplements could she be using to improve the side effect?
So there's a lot of research on vitamin D and estrogen deprivation therapies. But I would guess you're on aromatase inhibitors. So there's a lot of research on optimizing 25-OH vitamin D. But you have to remember that there are estrogen receptors in the connective tissue. And so you lose elasticity when you go through menopause or hormonal blockade therapy. And so that's some of the discomfort. It's not really inflammatory discomfort. It's like stiffness, right? And so also just stretching, doing a lot of range of motion, whether that's yoga or just a good stretching routine, actually is incredibly helpful. And honestly, some women suffer more than others with that. And in traditional Ayurveda, I have no science to back this up, but in traditional Ayurvedic medicine, they do golden milk, You know, they do
Yes.
a milk drink with ghee and turmeric in it, and that's a flexibility drink. And it's, of course, anti-inflammatory. I would say you want to keep your collagen healthy, you know, your connective tissue healthy. So, you know, get adequate protein. You could do collagen protein or bone broth or something like that if you want to. And acupuncture is incredible for that, incredible. But honestly, I find that if most women really keep their vitamin D optimized, like around 80, and do a lot of stretching, a lot of range of motion, sometimes that's all that's needed. And honestly, you know, you get stiff when you go through menopause too. Not that stiff as on the drugs, but you know, it's an issue of lower estrogen.
All right. Excellent. I think that is the end of the questions.
Okay. Well, this was really fun for me. I hope it was valuable for everyone.
Very, very valuable and very practical. That is what we like.
Yeah.
So we're ready. We have, you know, most of the supplements you were talking about. Not only do we have available through Designs for Health, but many others could also be available, like curcumin and some others that we don't yet have because we have them, you know, on our way.
Yeah.
Uh-huh.
Yeah.
So I am very grateful, Dr. Nalini, for having you, and I'm sure that all of us are as well, you know, happy and eager to learn from you and start, you know, trying this with our patients. It's so valuable because of the plenty years of experience and success that you have had over time.
Yes. So I actually, you know, for those that are really interested, you can check out my course for 30 days at no risk and see if it is a fit for you. It's about 30 hours of recorded lectures, and then there's a monthly case supervision for people who want that. And so, you know, there's probably a subset of people here that are that.
Yes, absolutely.
You know, right.
Absolutely. And we will make sure that everyone of our attendees tonight receive the recording. And will we be having your PowerPoint presentation? Is that something that we will be able to access?
I think we made a PDF version that we sent to
Okay.
you, give to everybody. I think Astrid, my assistant, shared that with you. But if not, just ask her for it.
Okay, I will talk to Astrid tomorrow. I'm gonna check my email and see if we already have it. And if not, I will talk to Astrid tomorrow.
Yeah.
For sure.
Yeah. Okay.
All right. We have a thank you message.
A lot of muchas gracias, I'm seeing.
Muchas gracias, man. One of the things that one of our doctors is saying, very easy to understand, which is, you know, that is very valuable because it's such a difficult topic that when you make it easy to understand, it's just great for all of us.
Yeah. I think it's important.
Yeah.
It's important. So
excellent.
Thank you for inviting me.
Thank you so much. Have a good night, everybody.
Good night, everyone.
Okay, bye-bye.